Okay, it's just gone 1 o'clock, everybody, and I think we've got most people joining us, so we'll get started. So thank you for joining us today at the Kirby Institute seminar series, and my name is Gail Matthews and I'll be chairing today's session. And I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today, the Bedegal people of the Eora Nation, and pay my respects to their elders past, present and emerging. And I extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. So just very brief housekeeping to begin with. As per usual, the format for the seminar today is actually just one presentation, and then we'll have a Q&A at the end. And if you can ask any questions that you wish to direct to Chan by clicking on the Q&A icon at the bottom of the screen, and you can do that throughout the presentation, and then we'll go through those at the end, and hopefully have plenty of time for some questions. So the last couple of years has taught us many things, and not least that we still don't know a lot, both about SARS-CoV-2 infection and viral infections in general. And I think one of the areas of research that's really been fascinating to watch develop is that related to long COVID, that novel phenomenon that we've seen occur post COVID-19 infection, but an area of research that can potentially also teach us many more insights into post-viral infection illness in general. So it's with pleasure that I introduce our speaker today, Dr. Chan Phetsouphanh. Chan recently returned to the Kirby Institute from his postdoctoral position at the University of Oxford in the UK. His projects involve the investigation of T-cell responses during SARS-CoV-2 infection and evaluating the immune signature of long COVID. He has keen interests in T-cell biology, infectious diseases, virally driven cancers, and immunopeptidomics. Chan is going to present his work today entitled Immunological Dysfunction Persists for 8 months following initial mild to moderate SARS-CoV-2 infection. So please welcome Chan.
Okay, before I begin, I'd like to acknowledge that this seminar is being held on the traditional lands of the Bedegal people of the Eora Nation, and pay my respects to elders past, present and emerging. So today I'll be giving a talk based on work we've recently published in Nature Immunology last month. And the title of this study is Immunological Dysfunction Persists for 8 months following initial mild moderate SARS-CoV-2 infection. And it's a collaborative work between us here at the Kirby Institute, St. Vincent's Hospital, collaborators down in the University of Melbourne, the Doherty Institute, as well as the University of Boston. And so this is just our talk, the talk outline for today. I'll give a brief overview of the condition that is long COVID, show results of measurements that we did on serum analytes, the mathematical modeling of the serum analyte data, as well as phenotyping results of innate and adaptive immune cells, and then summarize our findings and give out some future directions. So COVID-19 or coronavirus disease 2019, the illness caused by severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. Infection of this virus is characterized by a wide spectrum of clinical severities in the acute phase, ranging from asymptomatic to moderate to severe fatal forms. A proportion of surviving acute COVID-19 patients develop post-COVID syndrome, encompassing various physical and neuropsychiatric symptoms lasting longer than 12 weeks. And this condition is also known as chronic COVID syndrome, post-acute sequelae of COVID-19, and long-haul COVID. Persistent symptoms up to 6 months after hospitalization were observed in 76% of discharged patients in a study by Huang et al., with the most frequent of symptoms that were reported being muscle weakness and fatigue. Amongst community-managed COVID-19 cases, prevalence of persisting symptoms is much lower, but remains higher than what might be expected given the severity of the initial illness. And this can affect between 10 to 30% of individuals at 2 to 3 months post-infection. The spectrum of post-acute sequelae of COVID-19, henceforth denoted as long COVID, is broad and encompasses more than 50 symptoms, although characteristically manifests as severe relapsing fatigue, often accompanied by dyspnea or shortness of breath, chest tightness, coughs, and headache. However, the underlying pathophysiology of long COVID is poorly understood, and currently there is little evidence defining the mechanisms of systemic inflammation during or following COVID-19 infection, and not a lot of immune correlates of ongoing symptoms have been described. So to address this question, the ADAPT study was developed at St. Vincent's Hospital, and the ADAPT study is a prospective cohort of post-COVID-19 recovered patients, and we started recruiting in April in 2020 during the first wave in Australia. We recruited 147 participants with confirmed SARS-CoV-2 infection that were enrolled at St. Vincent's Hospital, mostly in the community-based clinics, with some patients also enrolled with confirmed infection at external sites. And long COVID was defined within the ADAPT study as patients with symptoms at 4-month time point, with the presence of a combination of the three most common symptoms being fatigue, dyspnea, and chest pain. And then a year later, the WHO, via a Delphi survey, a worldwide survey, came up with a long COVID definition, and which was defined as post-COVID-19 condition that occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of infection, with symptoms that last at least 2 months and cannot be explained by an alternative diagnosis, which is very similar to the initial definition that we use for the ADAPT study. And this table summarizes the patient characteristics of the patient and control groups that we use in our study. So the ADAPT main study was split into two, being the long COVID group and the match control group. 31 of the participants were defined as having long COVID, so about 21% of the study, with 8 having severe disease, 2 severe within the asymptomatic match controls, and about 39% within both groups having other comorbidities. What makes our study unique is that we also have a control group that were recently infected with common cold coronavirus infections. And so we had 25 of these participants that were either infected with the one or combination of the 4 common cold coronavirus strains. We also had 2 unexposed healthy control groups, one at St. Vincent's Hospital that we did the majority of the assays on, and one at the University of Melbourne that was a healthy control group for the plasma ACE2 assay. I think it is important to note that although our asymptomatic match control groups had no symptoms at 4 months, but during initial acute infection, they had similar symptoms to patients that later developed long COVID. However, in the match control groups, the symptoms were resolved during convalescence. So this diagram shows the sampling of biological specimens used for our study. So for both the long COVID group and the asymptomatic match controls, we did plasma ACE2 activity at 3 months, 4 months, and 8 months. We did ex vivo phenotyping at 3 months and 8 months, and measured serum analytes at 4 months and 8 months. And for the ADAPT-C study, or patients recently infected with common cold coronaviruses, we did plasma ACE2 activity and serum analytes at approximately 2 to 4 months post-infection. So as most people know, SARS-CoV-2 utilizes the catalytic site of full-length membrane-bound angiotensin-converting enzyme 2, or ACE2, for host cell entry. And usage of this is thought to downregulate membrane-bound ACE2 and thus contribute to ongoing inflammation due to loss of the degradative pathway of angiotensin 2. However, in patients with cardiovascular disease, there is an increase in shedding or cleavage of ACE2, and higher circulating levels are associated with downregulation of membrane-bound ACE2. So our collaborators in Melbourne measured plasma ACE2 catalytic activity using a validated sensitive quench fluorescence substrate-based in-house assay. And they showed in their publication that plasma ACE2 activity is elevated in patients after COVID-19 infection compared to uninfected age and gender matched controls with similar comorbidities. And interestingly, plasma ACE2 activity remained elevated out to a median of 114 days post-infection, as shown in the graphs below, where the SARS-CoV-2 positive subjects had a much more elevated plasma ACE2 activity compared to uninfected controls. And the elevation is much higher when stratified into disease severity. And it has been recently shown that higher plasma ACE2 concentration was associated with increased risk of major cardiovascular symptoms in a large global population study. And that studies are needed, other studies are needed to determine if persistent elevated plasma ACE2 activity may identify people at risk of prolonged illness or cardiac events following COVID-19 infection. So then we thought to measure plasma ACE2 activity in our long COVID control groups to see if this was also the case. And so we did find elevated plasma ACE2 activity in both the long COVID and the matched control groups at 3 months and 4 months post-infection. And it's much higher as compared to common cold coronavirus group and unexposed healthy donors. Although the plasma ACE2 activity sharply declined at 8 months post-infection in both the long COVID and matched control groups. So potentially a plasma ACE2 activity is more of a measure of acute infection rather than a chronic symptomology. So then we wanted to measure other biomarkers in serum of these patients. So we used a BioLegend kit. The first kit is a human antiviral response panel, so consisting of 13 analytes that were pro-inflammatory cytokines, type 1, type 3 interferons, as well as chemokines that are normally elevated during viral infections. And that we also designed a custom kit to look at analytes that have been previously described in literature as being associated with vascular inflammation, such as ICAM, BCAM, PCAM, CCL2, other markers that were associated with chronic fatigue syndrome, TGF-beta, IL-5, 13, and 9, and also recent publications that show an increase in certain cytokines in severe COVID-19. And this assay is a multiplex bead-based assay where beads coded with monoclonal antibodies specific for each analyte are added to the serum samples, and then a secondary biotinylated detecting antibody with streptavidin PE added to show fluorescence and measured through using a flow cytometer. And this is a quantitative assay. And so when we looked at all of these analytes using our patient samples, we saw increase in 6 of these analytes within the ADAPT groups, so long COVID and the match controls compared to common cold coronavirus and unexposed. And these included interferon beta, interferon lambda 1, CCL9, CCL10, IL-8, and soluble TIM3. However, at the 4-month time point, there was no difference between the levels between long COVID and match controls for any of these analytes. And then there was maintenance of these type 1 and type 3 interferons, however, when we measured these analytes at 8 months. And this graph shows that, yeah, the levels are still elevated within the COVID-19 patients compared to common cold coronavirus and unexposed healthy donors. But this is lost for the other 4 analytes. And then when we compare long COVID versus match controls, it's clear that type 1 interferon, interferon beta and interferon lambda 1 remain elevated in long COVID, and it's statistically higher than the match control group. So then we want to see if there was a relationship between the analytes when we correlated them against each other. And we did see an interesting inter-analyte correlation profile at 4 months with long COVID compared to match controls. So this kind of suggested that there was elevated diffuse inflammatory cytokine milieu happening at 4 months. However, this profile was lost at 8 months, and potentially due to the reduction in the majority of analytes analyzed, except for interferon beta and interferon lambda 1. We also did a Mantel test that compares correlation matrices and whether there's a difference between the matrices, and there was at 4 months, but not at 8 months. So we thought a better way to analyze the serum analyte data was to come up with a mathematical model that looks at the concentrations at 8 months and then can subset the analytes in groups and then compare them and potentially give out a prognostic value, whether they were associated with long COVID or not. And so this work was done by Dr. Daniel Wilson, and the model uses, so the I integer is the analyte, the concentration of the analyte, and giving weight to the individual patients, and then did a log linear classification of the weights. And then basically the function gives us a classifier, if it's greater than 0, that participant with that analyte concentration has long COVID, and if it's negative, they were asymptomatic match controls. So then we had to evaluate the model, and this is done by bootstrapping and machine learning. So due to the modest sample size that we had, because we had some patients that we didn't have the 8-month time point for, so this reduced our overall group from 62 down to 58 participants at 8 months. We performed bootstrapping to randomly sample new populations and with replacement, and then sample the population again, splitting them into test sets and training data sets. And then the readout that we get from this is, we'll get 2 readouts. One is the accuracy, which measures the proportion of the test participant that had their COVID-19 status correctly predicted using true positive, true negative, false positive, and false negatives. And then it also gives us an F1 score, which is a measure that combines recall, how many long COVID cases were correctly predicted, and precision of all the participants predicted to have long COVID, how many were correct. And this process was done, repeated with 1,000 different bootstrapped sampled populations, so 1,000 simulations. And the average accuracy of a model of N analytes is then calculated and used to assess which combination of N analytes performs the best. And our results show that interferon beta was the most highly associated analyte with long COVID. And with 1,000 simulations, interferon beta came up 90% of the time as the best analyte. And then we had different variations of the number of features. So the top 2 features were interferon beta and PTX3 with an accuracy of about 78.5% and an F1 score of 0.77. And then when we increased the number of analytes, the top 4 analytes were interferon beta, PTX3, interferon lambda 2, 3, and IL-6, which increased the accuracy to 81.59% with an F1 score of 0.8. And then when we used all of the analytes to see what accuracy and F1 score we get, it actually decreases the accuracy to 77% and 0.75. So using this data, we found the 4 most associated analytes long COVID were interferon beta, PTX3, interferon lambda 2, 3, and IL-6. And a way to visualize this data is that the linear classifiers can define what is known as a decision boundary, and a patient's analyte concentrations at 8 months will lie on either side of this boundary, and its positioning relative to the boundary will determine whether the patient is predicted to experience long COVID or asymptomatic COVID. And this is shown by the dot plot here, where the red dots are long COVID subjects, and the blue dots are the asymptomatic match controls. And you can see that the dots residing on the upper quadrant of the decision boundary are mostly long COVIDs. And so this model is able to predict with two analytes here, interferon beta and PTX3, 70% with 70% accuracy. However, using 4 analytes, the plot was actually 4-dimensional, which was hard to represent, but that increases our accuracy to 80%. And so the next thing we wanted to look at, now that we've seen elevated interferon, type 1 and type 3 interferon in the serum, is whether there are any increases in activation markers at the cellular level. So we measured immune phenotyping, and it's done with a 20-parameter flow cytometry panel that includes lineage markers for myeloid and adaptive immune cells, and included markers of cellular activation and exhaustion. So this is done by staining cells using fluorescent monoclonal antibodies that bind to surface marker expression of specific molecules. And the readout is done using spectral flow cytometry on the Cytek Aurora. And this is the readout that we get from flow cytometry. Each dot represents a cell, and we gate on lymphocytes, on single cells, live cells, so we exclude dead cells. And then we split the live cells into CD19 positive B cells, CD3 positive T cells, and then the T cells are then further separated into CD8 positive and CD4 positive T cells. So because it's a 20-parameter panel, we basically concatenated all the files all together and then did dimensional reduction using the TriMap algorithm, which is similar to a UMAP. And then it does a nearest neighbor clustering of the cells based on their phenotype. And with all the cells together there shown in the left panel in combined, we have CD8s shown in the purple gate, CD4 in the blue gate, and B cells in the green gate. And then we can split all of these into 2 groups, the long COVID and match controls. And you can see that there are 5 clear populations that are basically absent in long COVID at 3 months compared to match controls. And these absent populations include naive B cells, innate-like T cells, naive CD4 T cells, cytotoxic CD8 T cells, and naive cytotoxic CD8s. And what was interesting to us is that this absence of naive cells is quite interesting. So we wanted to dig further and see what the actual subset within naive cells, which subsets are actually absent. And so we did this by gating on all naive T cells and then doing a similar dimensional reduction and splitting them into separate clusters. And you can see in the upper part that cluster 5 and cluster 8 highlighted in red are the ones that have very low activation marker expression. So low TIM3, CD38, and HLA-DR. And these are absent in long COVID, so 0 cells were detected within the CD4 and CD8 compartments. And this was the same again in B cells, which suggests to us that potentially due to the inflammation that is happening, these unactivated naive cells are actually turning over and becoming more activated because of the inflammatory cytokine milieu. And when we did this again at the 8-month time point, interestingly, there was some reconstitution of the innate-like T cells, so the black bars had increased, as well as the cytotoxic CD8s. But again, the unactivated naive B and T cells remained absent. And then we also had a look at activation and exhaustion markers on T cells. So this has been very well described in literature. And what we found was there was no difference in PD-1 expression on CD4s, but it is much higher in CD8s, on CD8s in long COVID compared to match controls at 3 and 8 months post-infection. And this was similar when you looked at the exhaustion marker TIM3, it was high expression at 3 months in long COVID subjects compared to match controls. And the next thing we wanted to have a look at was to see if there were any differences in activation between myeloid cell compartments. And we did this by gating on CD16 and CD14 for monocytes, then using HLA-DR and CD11C to identify myeloid-derived dendritic cells, and CD123 to identify plasmacytoid dendritic cells. And these plasmacytoid dendritic cells are the main producers of type 1 interferon. So what we found was the highly activated monocytes, or in this case, non-lymphoid or myeloid cells at the 8-month time point. So they had higher expression of combined CD38 and HLA-DR at 8 months compared to matched controls. And this was the same when we looked at further subdividing into monocytes and plasmacytoid dendritic cells. We saw no difference in myeloid dendritic cells. So potentially the activation that we see contributes to the elevated type 1 and type 3 interferon that we see in serum, as these cells are the main producers of those interferons. So to summarize our data, so our data strongly suggests that there is ongoing sustained inflammatory response following mild to moderate acute COVID-19 infection. And this is not found following infections with other prevalent endemic common cold coronaviruses. In those with persistent long COVID symptoms, as distinct from asymptomatic convalescence, there is a sustained increase out to at least 8 months in highly activated myeloid cells, particularly monocytes and plasmacytoid dendritic cells, which most likely contributes to the sustained elevation of inflammatory cytokines, in particular type 1 and type 3 interferons, despite the majority of the cohort suffering initial mild moderate illness. Also, there was evidence of sustained activation of the adaptive immune system with perturbations of both naive and memory effector cell counterparts. We saw an absence of the unactivated naive T and B cells, and an increase in the expression of checkpoint molecules, so activation and exhaustion markers, PD1 and TIM3 on CD8 memory T cells. This widespread activation signature also reflects in the identification of serum levels of interferon beta, interferon lambda 2/3, interferon gamma, IL-6, and PTX3 as the 4 best features that's most strongly associated, the 5 best features most strongly associated with long COVID. And the drivers of this activation require further investigation, but possibilities or hypotheses include persistence of antigen, that it could be an autoimmune phenomenon driven by unexpected antigenic cross-reactivity, or a reflection of damage repair. So together, taken together, these findings suggest that SARS-CoV-2 infection exerts a unique residual prolonged effect on aspects of both the innate and the adaptive immune systems, and that this may be driving the post-COVID symptomology known as long COVID. So I also would like to point out that our study did have some limitations, that although our long COVID cases and controls were matched for 2 major characteristics, age and gender, it is possible that the differences observed reflect other key demographic or other factors between the groups. And also due to the timing of the ethics approval and cohort setup, we were not able to collect samples at acute infection. We therefore were unable to differentiate whether the elevations in biomarkers seen during convalescence correlate with levels during the acute infection. And the findings in our study also need further validation from bigger cohorts before, I guess, we can choose any targets for therapeutic interventions. So further work to continue this work on, we also would like to look at serum analytes at 1 year and 18-month time points to see whether type 1, type 3 interferons are still elevated in long COVID patients. We also would like to see if the immune activation that we see both in the myeloid and adaptive immune cells, whether they remain elevated as well post-vaccination. So we do have vaccinated time points as well. So future directions. So we also are interested in looking at other biomarkers that we haven't previously measured. And we thought to do this in unbiased ways to look at serum proteomics, so to measure the most abundant proteins in serum, as well as saliva. And one of the theories we have of what may be driving this inflammation is antigenic persistence. So we also would like to look at whether there is a presence of antigen in these later time points in long COVID individuals by looking in tissue and potentially sputum. So this would be another, I guess, sub-study from ADAPT that we would like to look into. I'd like to acknowledge all of everyone involved for making this study go ahead, particularly people at the Kirby Institute and St. Vincent's Hospital. So Tony, Gail, Greg, David, Annette and Milling, our collaborators at the University of Melbourne, Stephen, Louise, Sheila and Jen Juno, and Dan Wilson for doing all the mathematical modeling work from the University of Boston. I'd like to thank the ADAPT Clinical Trials Unit, AMR, all our cohort participants, Emma at the Flow Facility and Vera for proofreading the manuscript.
Thanks, Chan. That was a really fantastic job at explaining what is an incredibly sort of complex area to any sort of non-immunologist. And so you did a really great job at that. And so please, people, ask some questions in the chat for Chan. I think I will just start by asking, I mean, obviously I've been involved in this work, but I still got a lot of questions, I think, sort of around it, and sort of also questions that patients sort of direct to us, when we talk about these kind of findings. And one of the first things I was going to ask you was, I think we were all taken aback a bit actually by how striking the findings were with those elevation of cytokines in our COVID, particularly the long COVID patients at 4 and 8 months compared to the matched controls. And it was really nice that we had that group of people who had common cold viruses as a control group, who obviously didn't display the same elevation. I guess one of the questions that I had was, do you know, though, in other post-viral infections, so in infections that are more like influenza, that may be more systemic, that may have a sort of more systemic manifestation than just a sort of common cold, do we know if we see the same type of immunological profile or elevation in cytokines in people post other viruses? Because it has implications for post-viral illness as a whole. Mainly I think pro-inflammatory cytokines, so interferon gamma, some type 1 and type 2 interferons have been described, but I think the time point is in long COVID, it's much further out than other post-viral illnesses that tend to resolve a bit earlier than, say, in what we have observed in long COVID. And I think in the ADAPT, it's gone up to the 18-month time point, and people are still having symptoms. We do need to measure these interferons at those later time points, whether they remain elevated or not. I guess one of the difficulties has always been in people post other viral infections, whether it's EBV, influenza, etc., is actually having a cohort that you can actually follow, and identifying those people who may remain sort of symptomatic or take a long time to recover versus, those people who are fully recovered, and collecting specimens on them in such a sort of a well-defined, well-characterized manner. And I think that's where COVID-19 has really given us some potential insight. So a couple of questions coming through now. I guess the first one is from somebody who's had COVID and then has been told that they have HLH and T cells not function and B cells are immature, and whether that sort of also happened after COVID. And I guess without obviously responding to obviously a specific question about somebody's illness, can you talk in general about sort of, these kind of immunological disturbances? I guess it relates a little bit to my prior question, but whether in general we see them after COVID and other disturbances.
I think that there's a lot of literature actually out there and describing immune dysfunction, particularly in severe condition or hospitalized. I think what's surprising is that our cohort is majority are mild and moderate. So we didn't expect to see that, high activation in their immune cells, as well as increase in exhaustion in their T cells, which is quite surprising. But the absence of the unactivated naive cells, I think, reflect the inflammatory cytokine milieu, because what we're measuring is peripheral blood immune cells. So they are getting, I think, activated while they're in circulation. And so potentially, there is dysfunction there, because generally these cytokines, particularly interferons, basically just disappear following convalescence.
And a couple more questions, which again sort of are related to the same theme, although slightly different, in the sense that these are now asking really about chronic fatigue syndrome, ME, and of course that's one of the areas I think that has been quite challenging in terms of thinking about long COVID, and about whether it's a similar illness to ME or CFS, or whether it's different, or how we can learn from it, I think. So again, separate from literally post-viral, do we have any information about people with long-term ME, CSF?
Yeah, we did scan through the literature of ME, CSF. We did include those analytes that have previously been described to be elevated in chronic fatigue syndrome in our initial serum analyte measurements, but none of those analytes that were described actually showed a difference in our cohorts. So we didn't see that.
So not obviously the same pattern, although it's so complex isn't it, to understand. I guess I also had a sort of further question. Again, it comes often from patients, and I'll direct it to you, but also direct it to Tony if he's online as well, because I think it's something which is really interesting. So these biomarkers, what can it tell us, or how can it lead us to therapeutic intervention? Because whether it's around long COVID, or again how it may impact on chronic fatigue, etc., are these therapeutic targets, these elevated interferons? How do we go about sort of moving from this to the translational?
I guess it would still be important to know what is, I guess, the cause of these elevated levels. Like, why are these innate immune cells still making interferons? So one of the potential hypotheses we have is persistent antigen. So I guess if we can find antigen still within these cells or within tissue, potentially trying to get rid of these persistent antigen may help reduce interferon levels. In terms of therapeutics, I think there's only inhibitory drugs done in animal models, so it hasn't progressed from there. So if there are going to be further work, I think there needs to be confirmation that this is observed in other long COVID cohorts, and potentially preclinical work done in animal models before we move forward with this.
And I guess my worry, I'll ask Tony to comment, but I guess my worry is also when people say, well, why can't you just target this? Because from a very simple non-immunologist point of view, the immune system is so complex up and downstream that to come in at one point and sort of try and manipulate sort of markers or cytokines, it could do more harm than good, right? If you don't understand, which is what you're saying, you need to understand the cause. Yeah.
I don't know if Tony has other comments.
Yeah, I've thought about this a little bit, and I think you've gone a long way to answering this, Chan. I guess I'd add to Gail's observation that, because there's not so one, I think we need to understand why these things are up, and preferably turn off what the cause of this is. So go upstream of this, and Chan's looking at that at the moment. But, you could guess about that. At the moment, we don't have any drugs that specifically turn off either interferon beta or interferon lambda, let alone both. And so you would need to embark on either something that changed antigen presentation, and perhaps, I'm going to have house a derision now, something like hydroxychloroquine, which changes antigen. One of the mechanisms by which hydroxychloroquine works in autoimmune disease is thought to be changing antigen presentation. And so that possibly would change the activity of the monocytes and the plasmacytoid dendritic cells. The other way to do this, though, is to go in with some fairly robust immunosuppression, like corticosteroids, which have, significant adverse toxicity profiles, and then or more suppressive generalized immunosuppressants. So, there is a danger to that, particularly in the midst of a COVID epidemic, of then predisposing people to reinfection with a range of other viruses, including COVID. So I think we need to be, I guess I'd be, I think this needs to be done in the context of a clinical trial. And I think the sort of work that Chan's doing to try and get to the root cause would guide more rational therapeutic interventions.
And I think it's sort of, it's interesting to reflect, because you mentioned it briefly, Chan, in your sort of future directions around vaccination, because again, from patients, when they talk to us, they talk about actually feeling a lot better post-vaccination. In fact, I had one patient who said that, she had a loss of smell and some other sort of symptoms along COVID. And she said I just talked to the other day, she said she had her booster and suddenly it's all gone away. But, that might, but anecdotally, patients do seem to, and has been reported that patients do improve after vaccination. So what's the rationale? Is there a biological basis for that based on your hypothesis? And tell us, and you're looking at that in this cohort, aren't you?
Yes. So whether there's been some shift in I guess the overall equilibrium of the immune system post-vaccination, whether having an increase in SARS-CoV-2 specific T cells and B cells, whether that helps clear any persisting antigen. So these are all speculations that we need to test, but I think potentially, could be one of the few things that are happening post-vaccination. And just with preliminary data that we looked at, there is some reduction in those exhaustion markers, but it's still a bit early to tell at the moment.
Okay, great. And there's one final question we've got at least in the chat here at the moment, which is around, I guess it's more around the sort of long-term implications for these findings. I mean, obviously this is a small cohort and needs to be replicated, but if there is this sustained immunological sort of activation post-COVID infection that occurs, at least in some people, what are the implications of this for cancer, for long-term cardiovascular disease, other infectious diseases, etc. And how do we sort of measure that, or what we can? Yeah,
I think that's a really good question, but really difficult to answer. I guess with what we've observed so far, it might, so people with, like high levels of inflammation and absence of naive cells and also exhausted T cells, they potentially might not respond well to new infections. So I guess they require further monitoring, in the clinic to see if that is the case or not. But I think, we'll need a fairly big cohort to do that and follow systematically, longitudinally, as well as, other new infections that may arise and how the immune system responds to those new infections.
Yeah, and I think, look, hopefully when we continue to follow this cohort out, we will see that immune activation signal, fall down or decrease. And we're about to look at them at 18 months and short at 2 years. So hopefully we'll see that sort of signal disappear. But I think in general, to the point, I think it's really also why it's so important to do big data linkage studies, right? For example, in New South Wales or wherever we can do it, that actually link people who've had COVID with long-term health outcomes and starts to look at these, while I can't look at it at the biological level, can certainly start to look at it at the sort of population level in terms of really whether there is any impact. And I think, as I said at the beginning, we're still learning so much about COVID-19 infection and its impacts both in the acute and post-acute and probably the long term as well. So Yes, it's more questions than answers really, but amazing work, really elegant experiments and sort of thoughts in terms of sort of next steps. So congratulations. I don't know. Oh, there is one more question. Sorry, briefly before we go. Are there any studies, we didn't touch on this, but yeah, Chan, are there any studies about this immune responses to different COVID variants? So maybe we'll just say a bit about that quickly. Yeah,
so there have been, but not within the context of long COVID. So mainly convalescence and post vaccination. So there's good, I guess, T cell responses to the variants, particularly Omicron, where you see a drop in neutralizing antibodies. But we do plan to do that with our long COVID cohort. So I do plan to look at immune responses to the different variants really soon when the reagents arrive. And we've got, we certainly recruited patients from the Delta wave, and we're just about to start recruiting hopefully from Omicron, and we'll follow those patients up. It will give us a nice comparative sample. So yes, we don't know yet, I think is the answer though, certainly to the Omicron question. Okay, well, unless there is any other questions or comments, I think we'll wrap it up there. Great job, Chan. Right, thank you. Thanks, Gail.
Thanks. Thanks, everybody. Outstanding work, Chan. Well done.